Good morning and welcome. Happy Friday.
Happy Friday.
There you go. We are going to give folks just a few minutes, like we usually do, to log on and settle in and make sure they have their coffee or whatever they like to have. So if you want to introduce yourself in the chat, just drop your name and your organization in the chat so we know who's here with us today. That would be great. And we'll get started in just a couple minutes. Good morning and welcome to everyone who's logging on now. Good morning, Dr. Scott and Adriana. If you haven't already done so, you can drop your name and your organization into the chat. Just to know who's here with us this morning. Good morning and welcome. We'll give folks just another couple minutes. Good morning and welcome to all of those who are joining us now. Good morning and happy Friday. Welcome to today's webinar. If you haven't already done so, you can drop your name and your organization into the chat so we know who's here with us today. Good morning and welcome. Good morning, Linda. And Robin. We'll give it just one more minute. To those who have just joined us, please drop your name and organization into the chat if you'd like. Let us know you're here. And we'll get started in just a minute. Good morning and welcome, everyone. I think it's time to get started. Um, Good morning and welcome to the webinar. My name is Laura Brooks, and I'm with the Community Mental Health Board of Oak Park Township. For those of you who are new to our professional development workshops, welcome. For those who have been here before, welcome back. On behalf of the Mental Health Board and River Edge Hospital, thank you for taking the time to be with us this morning. In addition to our speaker, who I'll introduce in a moment, I'm joined here today by my colleague from the Community Mental Health Board, Melissa Lobring, as well as by Alex Moran from River Edge Hospital. Before we get started, we have just a few housekeeping items to go over. First, our speaker would like this to be an engaging workshop, so if you haven't done so already, please feel free to introduce yourself in the chat, just your name and your organization. If at any point this morning you experience any technical difficulties, please chat the hosts and we will do our best to address that. Next, our presenter has saved some time for Q&A, so if you have questions for him, feel free to drop them into the Q&A so we don't lose them in the chat. Also, he has built in a brief break midway through today's presentation, so we'll all have an opportunity to step away for a few moments to grab a coffee or a tea or a water refill or to stretch or do whatever we need to do for ourselves. Finally, and importantly, I want to cover our CEU procedures. To be eligible for CEUs, you must participate in at least 75% of today's webinar, and you also must fill out an evaluation by the deadline. Due to requirements implemented by the state related to CEUs for virtual workshops, you will now also have to complete a post-test, passing with a score of 80% or greater in 3 attempts by the deadline. We will post a link to the evaluation and post-test in the chat at the end of today's webinar, so you'll be able to fill them out immediately. We will also email a link to the evaluation and post-test later today. Both will be open for 1 week through Friday, December 19th. After the evaluation and post-test close, CEU certificates will be emailed within 2 to 3 weeks to those who attended at least 75% of today's webinar, submitted an evaluation by the deadline, and passed the post-test with a score of at least 80% in 3 attempts by the deadline. If you have any CEU questions, please contact the organizers through Eventbrite. Okay, without further ado, let's get started with today's presentation. We're so pleased to have Scott Mulligan with us today to present his workshop, Suicide Prevention Using the CARES Framework. Scott is a licensed professional counselor and mobile crisis therapist specializing in suicide prevention, trauma-informed care, and crisis intervention. Drawing from over a decade of experience helping individuals in their darkest moments, he blends Adlerian principles with practical, compassionate strategies that foster hope, resilience, and recovery. In today's webinar, Scott will equip us with knowledge to help us recognize warning signs of suicidal ideation, respond effectively to suicidal crises, and foster hope through the CARE framework: connect, assess, respond, and empower. And he'll share communication strategies that reduce stigma and promote long-term recovery and resilience across diverse cultural and developmental contexts. With that, I'm pleased to turn it over to Scott.
Thanks, Laura. I really appreciate that introduction. It's a pleasure to meet everybody. Thanks so much for joining this presentation. Um, I see a lot of people, social workers and counselors, all from different environments, some at school, some at hospitals, some in different practices, some that are just graduating, maybe their graduate program. So it looks like a whole host of different people. And I just want to thank you guys for the work that you do. And I know this is really hard work. And so I just, want to show some appreciation to you, and for joining me, right? Because suicide is a very heavy topic, for a lot of people. For people outside of the mental health profession, suicide is almost like a taboo subject. We want to talk about what are some of the best ways that we can prevent somebody from acting on suicide, using once you suspect somebody might be suicidal, using the CARES framework. And the CARES framework is just something we made up to remind ourselves what's most important when we're engaging with somebody who's in a suicidal crisis. And so throughout the presentation, I'm going to be bringing up different tools that we use to screen and assess somebody once we suspect they might be suicidal, and then how do we safety plan with those individuals to prevent anything from happening in the future, and then what kind of follow-up is useful to kind of empower those folks and keep them along their journey. So, really, like I just mentioned, we want to understand the epidemiology of suicide, right? Why is it important? We'll talk about some of the validated tools that, I work at Thrive Counseling. I've worked at community counseling centers of Chicago doing SAS crisis work. I'm a crisis therapist right now, and so we use different tools to screen people for suicidality. And we'll talk about what are the two useful tools that we use that are empirically proven to screen and assess somebody. And then we'll talk about safety planning, which is really kind of an important piece where we use the Stanley Brown method, which is a 6-step process of safety planning with somebody who's suicidal. We'll talk about what that is, but it's been shown to reduce suicidality by 46% of those individuals who have ascribed themselves being actively suicidal. And then finally, we'll talk about counsel on means. So, the more we can create distance between someone who's suicidal and their means of completing suicide, the more likely we can prevent them from committing suicide. So we'll talk a little bit about how do you counsel somebody who maybe has access to pills, maybe has access to firearms, maybe has access to sharp objects or chemicals in the house. How do we counsel that individual to create distance between those things and himself for a period of time to keep them safe? I won't spend a lot of time here, but guys, suicide matters to me personally. I know that a lot of you may have experienced somebody who attempted or, successfully committed suicide. If at any point during this presentation, this is very triggering, and you feel like you need to step away for a while, it's okay. It's heavy material and sometimes it could be emotionally triggering. Personally, I've lost close people to me growing up through the years to suicide, and those losses changed how I see people in pain. So my promise is simple to people that are in pain. I'm going to ask you directly. I will take everyone seriously. Everyone's trauma is different for everybody else. So I will never assume someone is just fine. And then I will fight for someone when they can't. And what you'll find is sometimes people that you think might be suicidal are afraid to talk about it or mention it, right? And there are ways to just ask questions to kind of get them to talk about it and disclose. And we'll talk about that a little bit. So, I don't want to read all these statistics, guys, but the ones that really glare and stick out to me is that in America, suicide is the 11th leading cause of death. But between the ages of 10 and 34 years is the second leading cause of death in America. So it's an epidemic because since 2000, youth suicide rates have increased 46%. And so 1 in 5 of us will consider suicide high school age and up at some point in our lives, right? So it's an epidemic, but it is the most preventable kind of death in America as well, right? And we'll talk about how you can disrupt and prevent somebody who might be actively suicidal. But I just wanted to mention this because it's critical amongst young people. And we'll talk a little bit about what are some of the risk factors. You know, I personally have done SAS work. So I've gone out in the field and done over 300 different assessments with adolescents and youth across Chicago public schools, all the major hospitals within the Chicagoland proper, including River's Edge and dozens of other hospitals, right? And the two things that stick out to somebody that self-harms in school or they're actively suicidal in school is because they're socially isolated and they've been bullied. Those seem to be the two highest risk factors that I see in youth. We can talk a little bit about more some of what are the other risk factors that you guys might see. But we'll talk about some strategies to prevent someone from committing suicide once you suspect that they're hurting. So we talked about the CARES model, right, which stands for connect, assess, reduce risk, support, and empower. And the reason we focus on connection is because it is the most important step in suicide prevention. Studies show that the therapeutic alliance stands as the single most powerful protector in suicide prevention. So what does that mean? Basically, it means if, whether you're a clinician, whether you're a social worker or a counselor or whatever your role is, you can reduce suicide risk by just making that person feel understood and validated, communicating unconditional positive regard for them, and then making them feel like they can trust you with their vulnerable disclosures. And we'll talk a little bit why that's important. So the interpersonal connection between you and that person who might be suicidal is the most important factor in the intervention. So alliance predicts engagement. What does that mean? Clients who feel connected to you are more likely going to show up and disclose to you what's hurting them and participate in treatment versus somebody who doesn't feel safe with you, right? So you want to earn their trust, right? Trust enables disclosure. And your connection with that individual is what's most important. Not what you say, but just showing up and your presence alone is the intervention, right? So, how do you build rapport with somebody who's in crisis? Probably the single most important intervention you can bring to the table is your presence. Okay. So, um, rapport creates the like a neurobiological and emotional safety in your brain necessary for everything else that follows. If you don't have rapport with somebody, they're most likely never going to want to be assessed by you. They're not going to want to safety plan with you, and they're not going to want to disclose to you. So nothing moves forward in the assessment process until you connect and build rapport with that particular client. And why is that important, right? Because when someone is in suicidal crisis, guys, their nervous system has shifted into a threat state. Have you ever felt like fight or flight before, where you're just like, holy cows, I'm late, or, something feels threatening to me and it's all I can focus on, right? Well, what happens is your nervous system shifts into a threat state and your amygdala, your brain's alarm center, gets activated. But your planning prefrontal cortex goes offline. So it's not a character flaw, it's just biology. So until you can make that person feel safe with you, no trust, no engagement. Rapport is not just about being nice or building a therapeutic relationship. It's about helping the person settle down their client, like their nervous system. And so when somebody's activated, how do you calm them down, right? And what builds trust, right? There's some verbal strategies that you can implement. I won't read all of these, but some of the ones that are really important is just validating them, right? What you're going through seems incredibly painful, or emotional labeling. It sounds like you're feeling trapped and hopeless. And then sometimes you can ask for permission by saying, would it be okay if I asked you about whatever's bothering you? So those are important, right? But I think what's even more important is the nonverbal strategies that you use when talking with someone who might be activated. I used to have a supervisor that told me, because I've done crisis work for many years, and I would go out to, different hospitals, different schools where a kiddo is extremely activated, wandering the hallways, destroying property, just besides themselves, right? And, they're at 100 degrees, right? But the key is to stay at 70 degrees. Your job is to be the thermostat in the room that sets the temperature. And how do you set the temperature? It's by using a very calm voice, by pacing yourself with your voice, speaking slowly and with a lower tone, and maybe gentle pacing, right? These things all kind of bring the conversation down to a manageable level. And then your body language is very important. You want to have sort of an open posture. You want to make eye contact, and you don't want to make them feel hurried, right? And try to match their rhythm, and don't rush. Those things will build trust, right? Let's talk about what doesn't build trust, guys. So we've all been in conversations where you can tell the person you're talking to isn't maybe attuned to what you're saying. Maybe they're not paying attention. But some of the things that happen with clinicians is that, and I'll be honest with you guys, I used to do uh, a lot of different assessments for community counseling centers in Chicago, and I would have 7 or 8 assessments I'd have to do a day. So as soon as I was doing one assessment, I'd have 3 or 4 waiting for me. And so I had to be careful because I didn't want to rush the assessment, because as soon as make someone feel rushed, they shut down. Okay. If you bring up legal talk, or you over reassure them, like everything will be okay, don't worry, Again, these are all things that are sort of incongruent. They're not sincere. They're disingenuous. Um, and it sends the message that you're just there to try to hurry up and get this finished, right? So avoid power struggles and using threatening language. The most important thing is don't minimize their pain, right? My trauma may feel a lot different than maybe someone who experienced the same thing, but don't minimize my pain. My pain feels intense. So with you, when you minimize my pain, it makes me feel like you don't really understand me. So these are all things that we don't want to do to break trust. I want to pause here. Any questions about rapport um, that you guys might have?
I don't see anything in the chat, Scott.
Okay, great. Let's
Yep.
power through. So just some final takeaways on rapport. Rapport is built through your presence. Stay calm, unhurried, and give them the attention that communicates that you care. In some of these situations, you may be the only person they think that actually cares about them, and that may be the difference in the world from them completing suicide and second guessing doing it. Validation precedes intervention. So before you can assess, plan, or problem solve, guys, the client has to feel heard and understood. So reflect back to them what you've heard, right? Use empathy and compassion. Use your use your skills, right? Of connecting with people because that's why you got into this field, right? Use those rapport building skills to make them feel heard and understood. And then once they trust you, that's when disclosure happens. And then collaborate with them on a safety plan. We'll talk a little bit more about that, but don't tell them what to do. Get them guessing and understanding, like, hey, as part of my plan is something that might be helpful, is something that I want to do. And once they own the plan, they're less likely to commit suicide. And remember, the clinician is the intervention, right? It's not some tool that you use to screen people. It's you showing up and attuning into that person, keeping your thermostat at 70, calming them down, and then screening and assessing them for safety and risk. I'm going to leave this with you guys. We're going to send a printout of this presentation to you guys, but I put together a 1 minute rapport script for somebody that you might be dealing with who's like acutely hurting. Maybe they've expressed passive suicide. Maybe they've made statements, right? But these are ways you can kind of validate and offer hope, right? One of the things that is really helpful is just to let somebody know, like, look, you're not alone in this. I'm going to be with you through these moments together. And together, we're going to get through this one step at a time. Okay. Um, that can be very helpful and reassuring to somebody who's feeling like, I don't know where else to go and I don't know what else to do. So let's ask a quick poll. Let's ask a quick poll. So someone says, I don't want to be here anymore. Okay. A client makes a statement during your session. This moment requires clinical judgment, careful assessment, and therapeutic skill. What would your first clinical step be if someone said, I don't want to be here anymore? Would you first jump immediately into a safety plan? Would you ask directly about suicidal thoughts? Would you call 911 or security right away? Or would you explore stressors and build rapport first? What do you guys think? Type it into the chat.
And I see some responses coming in. We've got two, a bunch of fours, another
Yep.
two, some twos and fours looks like what is what we're getting.
All
More,
right.
more fours than twos, but let's see.
Okay.
I don't know. The twos are kind of we've got it might be neck and neck.
Yeah,
Yeah.
so this is great because I think you know, from my perspective, someone says to me, I don't want to be here anymore. The first thing I would want to do is the first thing I would want to say is, um, do you have a plan, right? What's your plan? And then what's your timeline? Like, is this something that you've been planning? Do you have a timeline and do you have intent, right? So right away, I would want to jump to asking them directly about suicidal thoughts. Um, but if you feel like you haven't connected with that individual and you're sort of interviewing them and they say, I don't want to be here anymore, you can explore stressors and build rapport first because uh, for example, you may not know what that means. What do you mean you don't want to be here anymore? What's going on? You might want to get more information. So I think both can be correct. And I don't think either answers are wrong. I think it sort of depends on the situation, right? Um, and how well you know the contact. If you feel like you have some rapport with them and this is just something that they've said, yes, I would go directly to assessing them for risk. Um, but if it isn't something that you feel like you've got a good rapport with, yes, back up, get some rapport by asking good questions about what's stressing you out, what's making you feel this way, what's number one or two on the list that's making you feel so awful, right? And then ask the question about, are you feeling suicidal? Like, do you have a plan? Do you have intent? Like, and then you can from there safety plan, or in the case if someone is actively suicidal, right, and they check all the boxes, they have a plan, they have intent, and they have a timeline, then you might have to hospitalize that particular person, which I've done several times, which I don't like to do, but sometimes you need to keep them safe. So good job, everybody. I appreciate you participating. So let's talk about the role of screening, right? Let's say you suspect somebody is, they've been withdrawn and they've been sad, and you suspect that they might be suicidal, right? We use a couple different screening tools that allow us to like understand like, is there something there? Kind of like a metal detector on the beach. When it goes off, it tells you, hey, there's something underneath the sand. We don't know what it is, but it's there. So screening tools are the same way for suicide prevention. Sometimes suicide risk does not always present overtly. People don't come out and say, yes, I'm suicidal. So we have to ask them questions. And so I'm not sure if you guys are familiar with some of the tools that I'm going to talk about, but we use the PHQ-9 tool. It's a tool used to assess for depression, but there's one question on the tool. It's number 9 on the PHQ-9. And it's a simple question that we ask. It's a one question, yes or no answer. If they answer yes, we then move on to like understand the severity and risk of that person. Um, and then from screening, when we understand somebody is suicidal or they're flagged for it, then we would do an assessment to understand their severity. So for example, over the last 2 weeks, how often have you been bothered by thoughts that you would be better off dead or of hurting yourself? Any response greater than 0, so yes or no, means that you should move on and assess them a little bit further to understand their level of risk. So it's a single question, but it serves as a gateway to further assessment, and it's been validated across many diverse populations and clinical settings. If they answer yes, you can use the ASQ, which is Ask Suicide Screening Questions tool. The ASQ is a 4-item screening instrument provided by the National Institute of Mental Health, and it takes less than 1 minute to administer. Um, and so you're going to ask, in the past 2 weeks, have you wished you were dead? And then in the past few weeks, have you felt that you or your family would be better off if you were dead? In the past week, have you been having thoughts about killing yourself? And then four, have you ever tried to kill yourself? Okay. So in less than a minute, any yes triggers an assessment, guys. So anyone who answers yes to this means, okay, we need to assess for their severity and what's their risk level so then we can make a determination of what do we do next, right? But the ASQ has been validated in emergency departments, primary care, schools, outpatient mental health clinics, and it's an easy tool to use. So I'd recommend that it's a tool that you can use in those settings. So let's say you assess somebody with the PHQ-9 or the ASQ tool, and you get a positive flag. Then we want to know, kind of understand the risk stratification, right? We must understand kind of like who's low risk, moderate risk, and high risk, right? And what do we do in those instances? We consider somebody low risk if they said, hey, I think about suicide, but I don't have a plan. I don't have any intent or I haven't prepared anything. It's just something that I get a feeling about and, but that's it. So that's kind of a low risk, right? We recommend some kind of outpatient care, safety planning, obviously, and close monitoring. Let's say you run into somebody that says, look, I am actively suicidal. Um, you know, I'm feeling overwhelmed and I just want it to end. And there's other risk factors that you've identified, right? Maybe they're an increase in substance use. Maybe they just recently lost someone very close to them. Maybe you know that they have a history of attempts, um, but maybe they don't have any immediate plan or intent. So, meaning they're feeling overwhelmed, they've been using substance use, they've had significant loss, and maybe there was a history of attempt, but when you screen them, they said, no, I'm not currently suicidal and I don't have a plan or intent. That's kind of a moderate risk. So we want to increase the frequency of contact with those individuals, right? And so we want to make sure that we do like really good safety planning with them in case they run into a crisis again. And then, I've run into some individuals that are high risk. And what that means is that they're actively suicidal, but they have a specific plan and they have an intent to act and they have access to means to do it. So in those instances, right, that's when I've had to, unfortunately, with SAS, with parental consent, we've had to hospitalize kids to keep them stable and safe, as well as adults, sometimes voluntarily and sometimes involuntarily, right? But it's important that if they're in that active state like that, that we do keep them safe. So, um, client's risk level can fluctuate too, based on substance use, right? Substance use can kind of exacerbate this client's feelings, or different life events, right? Maybe they lost their job and they're already kind of depressed and it's one final blow. Access to means is very important. We'll talk a little bit about that. And their overall emotional state. And so continuous reassessment is critical, right? To kind of see where that person is at. So once you've screened somebody, I'm sure you guys are familiar with these tools, some of these tools, some of you. We use for assessments the CSSRS. It's the Columbia Suicide Severity Rating Scale. It's considered the gold standard for suicide risk evaluation. It's very widely used, and it's rigorously validated for assessing suicide risk. But what I like about it is that it helps you document the presence, intensity, and immediacy of suicidal thoughts and behaviors so that you can plan around it. So it looks at things like ideation. So you can document the presence and severity of suicidal thoughts, ranging from passive to active, with a specific plan. And then also intent and planning. So differentiate between vague thoughts and then someone who has like concrete legal plans, which is critical for determining level of care, right? If someone just has a random vague thought about suicide, that's quite a bit different than somebody who has a plan and immediacy for action. And then their behavior, right? Have they had past suicide attempts? Because that's a huge risk factor. Or aborted attempts, or maybe they've had interrupted attempts, but they've made preparatory actions in the past, such as acquiring means. So what this allows us to do is understand just sort of the intensity and immediacy of this particular individual. And, it's considered essential for thorough clinical documentation, whether you're in a hospital, whether you work in crisis or research settings. But it supports clinical decision making and it's legally defensible. Any questions, you guys?
Hi, Scott. Yes, we have a couple questions actually.
Yeah,
One person asked in the Q&A, how can you
yeah,
hospitalize someone against their will? That was from Frank.
yeah. So, if somebody is actively suicidal, or we feel like they're deteriorating, decompensating in such a way where they're at risk of hurting themselves or other individuals, um, certain agencies can fill out an MCRT, involuntary petition. It's a legal document that the crisis worker fills out with all the details as to why this person needs to be hospitalized to keep everybody and himself or herself safe. So it's a legal document that enforces a psychiatric evaluation at the local hospital. First, they have to be medically cleared, and then a psychiatric evaluation. Um, is petitioned by this by it's by law. So certain agencies have the power to do that. SAS has the power to involuntarily hospitalize kids as long as the parents consent. And so again, that's a process of paperwork. I forget the exact term for it, but yes, against their will, you can involuntarily hospitalize somebody. And I have had to do it, and that meant EMS and police having to sometimes restrain and immobilize that individual to get them care.
Great. We had another question come in when you were talking about, I think, suicidal ideation. Someone
Yeah.
asked, "What about I don't have what about when someone says, I don't have the mentality to kill myself, but I wish God would take me now."
Yeah. So that's somebody who's scared about committing suicide or scared of doing it, but wishes that God would take away the pain.
Yeah.
So what I'm hearing there is I'm in a lot of pain. I just wish God would take it away. I'm scared to take away the pain myself through suicidal means.
Mhm.
So I would still say that that person's very much at moderate risk. And at that point, I would want a safety plan with that particular individual to say, hey, when you're starting to feel like this, what are some of what's worked in the past in terms of internal coping strategies that have pulled you through these moments? And then what are some of the external people you can talk to about your feelings? Do you have any trusted adults or anyone that you can turn to when you have moments like this?
Mm.
What are some of the ways you distract yourself? And just develop a safety plan with them because it's ultra important that you guys are both on the same page that should something like this happen again, what is your plan versus suicide, right? Having a plan and owning it can prevent suicide, right? We've all had moments, I'm sure, I have, right, where my life felt, like it was in the gutter. I had no way out. It was painful. Um, but um, just having a friend there with me to get through the moment and then safety planning with me, like, hey, how are we going to deal with this when it happens again? Is extremely empowering, right? And just knowing someone cares um, can make all the difference in the world, right? The whole process of this, you know, suicide prevention is to get them to disclose, right? What are they hurting from? What are they feeling? And that process of disclosure can be extremely healing and in itself prevent suicide.
Great. We do have a few more questions. So why don't we take just a
Sure.
few more? Um,
Okay.
one person asked, in virtual therapy, how would you hospitalize someone who is suicidal?
Yeah. So in virtual therapy, what you can do is if you feel somebody is suicidal, and you're in a virtual therapy session, is um, you know, call the local crisis line, or the CARES line. Let them know that, you had a session, the person expressed SI. I'd like someone to go out and do a risk and safety assessment on this individual to make sure they're safe. And then, depending upon the location, depending upon, you know, the crisis line you use or 988 or CARES line, it'll get routed right to wherever that location is. And you can mobilize resources to come out to the home or to wherever that individual is to kind of do an assessment. And you can even say, look, you've made some statements that are very concerning. I want to make sure we can at least understand you where you're at from a safety and risk perspective, because maybe you do need a higher level of care. I won't know until we actually do this. So mobilize the resources to do the assessment if you can't do it virtually, because you're not going to be able to hospitalize somebody over a therapy session, right? But you can mobilize resources like myself, a crisis worker would come out, ask certain safety and risk questions of the individual to kind of assess them for intensity, and then make a determination on whether they should be hospitalized.
Great. Um, the next question we have is, when you ask the question, do you want to hurt yourself? And the person engages in self-harm as a coping strategy, but has no suicidal ideation, would you do further assessment for suicidal ideation?
Yeah, I would. I'd say, well, how often do you self-harm? Do you self-harm with the intent of killing yourself? If they say no, it's a coping strategy, then you still want to assess for, okay, do you have any plans? Do you have any timeline on when you want to do something? No, no, no. Are you currently suicidal? No, no, no. Okay. Then you're really dealing with like more of a self-harming situation, which is a coping strategy that, I see in a lot of kids. And a lot of times that coping strategy is due because there's some bullying, there's some changes in friendships where they no longer get along with certain friends, or they're outcast in some way, or it's pressure from family about grades and whatnot, and they feel less than. And sometimes you just want to ask, why do you self-harm? What's the purpose for you? Is it a release? Is it because of punishment? It could be different for everybody, but getting to understand the reasons why they self-harm, and then you can kind of take forward the type of therapeutic approach you want to take with them. But yeah, if they self-harm, always assess for safety and risk there. Like, hey, when you self-harm, are you doing that to kill yourself? Is that your intent? Yes or no? Do you feel like killing yourself? Yes or no? Um, and do you have any, have you in the past? Have you tried in the past? Yes, yes. No, no, no. Then you're in good shape, right? Then you know what you're dealing with.
Okay, last question for now. And it might be a big question, but you also might be getting to it in your presentation. I'm not sure. Um, Frank asks, how do you make a safety plan?
Oh, beautiful. Yeah, so we'll run through a safety plan, and we use the Stanley and Brown safety plan. It's a six-step safety plan that I'll run through in the presentation. So yeah, thanks for bringing that up. We'll talk about that. This is just a quick screening tool for quick reference, like when to use the screening tools, the PHQ-9 or the ASQ. And this is sort of a poll question. We'll skip this and come back. Um, all right. So let's talk about safety planning, right? Once you have identified the suicide risk, then you want to move into safety planning, right? Which is a collaborative written crisis response plan. The Stanley Brown plan has been shown to reduce suicide attempts by up to 45% when implemented correctly. And then we'll talk about lethal means restriction. So, how do we counsel families and clients to temporarily limit access to firearms, medications, and other lethal means? And so, yeah, this is the part of the CARES model where we want to, reduce and empower people through safety planning. So, what is the Stanley Brown Safety Plan, and you know, what is it comprised of? So, it's a six-step collaborative crisis intervention plan. And so, the first part of the plan is helping the individual understand their warning signs. They'll identify what are some of the personal, observable signs that a crisis might be building. Is it racing thoughts? Show me where it starts in your body, I ask clients a lot of times. Show me what you do. And in some cases, it's behavioral, where they will withdraw or increase substance use, right? And then when those types of warning signs that you start to be aware of, that's when we want to understand, like, what are some internal coping strategies you can use or activities that you can do alone to distract or self-soothe in those moments, right? So some examples are exercising. I recommend journaling a lot to my clients because it's a good way to get what's in your head out on paper. It can be very cathartic. I also teach my clients deep breathing exercises to kind of regulate their heart rate. And then listening to music seems to be very popular as well as a way to kind of distract yourself when feeling a crisis come on. Maybe one of the most important things that we see is that people who are suicidal tend to isolate. And the more isolated a person is, the higher risk they are of committing suicide. So, one of the most important things we can encourage them to do is socialize with others. So, it really may not matter. It could be like, hey, I don't have any friends. Okay, then go to the local coffee shop, sit down, grab a coffee, and just be around people, right? Don't isolate yourself at home. Be around people in some way. And then, the fourth step is to give them contact supports, right? Let's map out, like, in the case of an emergency, who would you call? Who's your emergency contact? Now, who's the person you would talk to if you had a mental health emergency? Who do you feel trustworthy that you could talk to? Who are those adults or people in your life? And then the fifth part is giving them the part of the safety plan is giving them professional contacts. So giving them your crisis line, right? Giving them the 988 line or the CARES line or whatever those emergency service lines that you guys might have for crisis. And then finally, reducing access to means, screening to make sure, hey, are there weapons in the house? Are there any prescription drugs in the house? Are there any knives or sharp objects in the house? Are there any chemicals in the house that could be life-threatening? And really counsel the individual, like, let's get those things kind of out of the house. Let's create distance between you and those means in some way. So let's take those steps to limit access to lethal means, because during a crisis period, what happens is when your prefrontal cortex shuts down, your thinking and reasoning goes out the window. When you're when you're, in an acute crisis situation like that and you're suicidal, it only lasts moments. But within those moments, if you have access to means, it could be the difference between life or death, right? So reducing lethal means encouraging temporary storage of firearms, right, with maybe a trusted friend or family member, and then removing or locking up prescription meds, over-the-counter pills, that could be used in overdose. And then obviously there's other means, right? Sharp objects, there could be cleaning chemicals, other methods specific to the client's particular space Temporary removal restriction can buy time for interventions to take effect. So here's just some warning signs, guys, and I'm sure, you guys are counselors and social workers and clinicians. So a lot of this might be redundant, but when you hear somebody that's hopeless, or the behavior changes, it's just out of character, they start to rage or they just show a little bit more irritability than usual, or they tell you that they've been feeling emotionally numb. Maybe they're like feeling detached and empty. You're unable to experience pleasure, right? They're adhedonia. Um, we see a lot of people that are suicidal with sleep disturbances, right? Insomnia or hypersomnia. Maybe they sleep all day, right? Or maybe they just don't sleep enough. And then overwhelming guilt or shame about something, right? Persistent self-blame or feelings of worthlessness. That's when you might ask the question, are you feeling suicidal? Um, and studies have shown when you ask that question directly to somebody, it actually makes that other person's anxiety decrease, right? Because it means you're trying to understand them and make them feel understood and heard. So don't be afraid to ask the question. External warning signs like social withdrawal, like all of a sudden they're isolating from friends and family, which was not their norm. Or you notice that they're using substance use more and more. A lot of times we see people that self-medicate with alcohol. They just want to blunt their feelings. But what they don't know is that alcohol is a depressant and makes them feel even worse over time, to the point where they make rash decisions. So substance use escalation, and then any preparatory behaviors like giving away prized possessions, starting to say like goodbyes to people, are all warning signs, right? If you notice someone's been researching methods online or asking about it, or talking about being a burden to other people, again, those are other warning signs. So, in terms of internal coping strategies when you're doing a safety plan, a lot of times what I'll recommend clients do is our grounding techniques, um, or breathing techniques. The 4-6-4 box breathing method sometimes, or practicing 5-4-3-2-1 method for deep breathing, just to ground that person, right? A lot of times we say physical movement, like taking a walk, or doing some kind of exercise, can provide a healthy outlet for emotional intensity. And then any type of sensory interruption, right? So a lot of times when people are ruminating over and over and over, they need some kind of sensory interruption to stop the ruminations. And so holding ice, taking a cold shower. Sometimes I'll have my clients put a rubber band around their wrist and just flick their wrist with the rubber band just to kind of snap them out of it, right? And keep them in the present. And my favorite thing to do is help clients, is to, journal their thoughts and feelings. Externalize the chaos that's going on in your head. And that can provide clarity and a sense of release. So these are just examples of internal coping strategies you can recommend. And again, the the spending time with others is huge. So encouraging going for a walk with a friend, spending time with friends, um, even attending a public place like a cafe or library, you don't feel so alone, right? So encouraging those kinds of activities as part of the safety plan, can be very helpful, as well as calling a family member to chat about everyday topics. It doesn't have to be about your mental health, right? Just talk to somebody, talk about whatever, but be around people. Um, and then participating in a community group or class. A lot of times this can be very helpful, like a DBT group or a grief group or whatever groups you guys offer. Consider, including that in the safety plan, because that can be very helpful, right? It's something for them to look forward to, and it's another way for them to be able to release some of what they're feeling to other people and not feeling so alone. Okay. Another thing I like to ask clients at the end of an assessment is, what's your reason for living, right? What do you live for? It's an important question, right? And people will give you all kinds of different answers, but it's another good way to kind of empower them, right? And keep them resilient, in the sense that, um, their recovery depends on this safety plan, right? So reasons for living, um, is really, really helpful. So, again, just some other coping tools. Um, we mentioned breathing exercises, right? Journaling, physical activity. And then what I like to do with clients too, if they're into journaling, is doing cognitive reframing. So I tell my clients, look, keep a log of your, daily, and then write down like I think and what you're thinking, I feel and what you're feeling, and then write something, but I know. So I think, I feel, but I know in a journal, right? So they can write down everything they're thinking. It may be crazy, it may be whatever that they think is awful or dark, how it makes them feel, right? Getting it out and then reframing that experience like, but I know things will be okay. But I know that I'm just overreacting, but I know whatever, right? So it's a good way to help them cognitively reframe using journaling. So these are just some evidence-based coping tools that work. And I would encourage you guys in your safety plans to encourage some of these things. And then we want to mobilize external resources as well, right? So when all else fails, their internal coping strategies fail, right? They can't reach out to their extended friends. They try to distract themselves, but nothing's working. They, did everything in the safety plan, but they're still feeling like they're in crisis. Well, let them know it's okay to call the crisis lifeline, right? It's okay to call 988, right? In those moments, use the external crisis hotlines, right? Because they're helpful. Talk to family and friends. And then, a lot of times I like to tell clients about drop-in centers or different community resources they can also use when they're not feeling so good, to be around other people, like peer support groups, communities, faith communities, etc. And then honestly understand like who are their medication and psychiatric providers. I like to understand when I'm doing a safety assessment, who's your primary care and who's your psychiatrist, right? Like when do you see them next? Okay, that's part of the plan, right? And then if you need to, coordinate plan with those physicians.
Scott, I think it's almost time for a break, and we've got a couple questions. Would now be a good spot?
Yeah, yeah. Let's
Great.
take some questions.
So we had a question come in where someone asked, is the care line for everyone and not just for students?
Yes, the CARES line's for everybody. So you can call the CARES line as a student, adult, either way.
Great, thank you. And then this question came in right at the end of the last point where you were answering questions. So it
Yeah.
might be in reference to um, trying to get help for someone during like a telehealth appointment. The question is,
Yeah.
if people refuse to provide identification needed for further contact, how can one provide resources? And if I have the context for that wrong, apologies to the question asker.
Yeah. Can you repeat the question again? I'm
Sure.
sorry.
The question is, if people refuse to provide identification needed for further contact, how can one provide resources?
Further contact. You mean in terms of like they don't provide an email or phone number kind of thing?
I think so.
Yeah. You can still, give them resources, right? Well, if it's virtually, you can verbally give them resources that they can write down, if it's possible. And then if, uh, you know, they're just refused to give their, they want to stay anonymous. I've had callers do that before. Um, that's fine. You can still verbally give them resources that they can use.
Mhm.
And at that point, it's up to them to use those resources.
Got it. Thank you. Okay, I think it's a perfect time for a break. It
Okay.
is about 10 o'clock. So why don't we plan to meet back here, everyone, at 10:10? And we'll see everyone back then. Enjoy your short break.
All right, sounds good. All right. All right. Welcome back, everybody. Appreciate you coming back. We were talking about external resources for support. Um, and I mentioned the CARES line, which is great. 988 is great as well. It's a great resource for people that need to talk to somebody that are feeling acute. And then at Thrive, we have our own crisis line for all essentially the villages, the townships that we service. But you guys may have your own. But yeah, keep that at the forefront for people to use if they're in crisis. And then sometimes it's good to help ask if like you can include family and friend members, someone who could be a trusted loved one in safety planning, right? Someone who knows their safety plan and knows what to do when they're feeling acutely in crisis. Um, Peer support groups are great. If you know of any for any particular individuals in crisis or feeling suicidal that they can feel more connected to. And there's a lot of different drop-in centers. There's now centers for LGBTQ centers, veteran services, etc., that provide belonging and reduce isolation. And then obviously, make sure that they're in touch with their PCP and their psychiatric providers. A lot of times I deal with clients that are off their meds. And when they're off their meds, their symptoms rebound. And when their symptoms rebound, they feel depressed. And when they feel depressed, sometimes they may feel suicidal or feel really yucky, right? So when someone's not compliant with their medication, um, there's part of the plan is when do you see your PCP next, right? When do you see your psychiatrist next, right? Are you going to make an appointment? Let's get those going. So just that we have a safety net around not only the internal coping strategies, their social contacts, but external providers like this. And so one of the things that we found is that the highest risk periods for suicide is immediately following discharge from like a psychiatric hospital or psychiatric care. What research shows though is after a suicidal like crisis, and once it's been de-escalated and you've safety planned and you guys go along your merry way, one of the most effective things to do to empower and support that individual is just like the next day or 2 days later, follow up. Follow up with a message, email, text, phone call. Hey, I'm just checking in on you. Want to make sure you've scheduled your next appointment. Want to make sure you're okay. And just do a quick safety check-in with them. That can mean a huge difference in their recovery because it shows that, maybe there is someone in this world that does care about me, right? Maybe I'm not so alone in this world and I just need that extra support and encouragement. So to support somebody that's gone through that, follow up with them when you're done with the crisis, right? When you're done with your assessment and when you're done with that or with your assessment with them. So here's a case study, guys, that I just want to review with you. Here is a LGBTQ youth. And in this particular case, um, whoops. In this particular case, it's a 16-year-old gender nonconforming youth, and they present with passive suicidal ideation following escalating bullying at school. Okay, the client feels hopeless and feels like a burden to their family. No active plan or intent is present, but risk factors include minority stress, um, lack of affirming support, and recent emotional dysregulation. So, using like kind of the CARES model that we talked about, the first thing you want to do is connect. So, in this instance, you want to connect with the person and validate that their experience of being discriminated against and also affirmed their identity. Sometimes it's very helpful to understand, like, hey, what are your pronouns? So I, can refer to you by the correct pronouns. Goes a long way towards building rapport with somebody. So build trust by using, correct pronouns and then expressing unconditional support. And that may mean just by telling them, look, I'm here with you. We're going to get through this together. And these are tough moments that you don't have to be alone. And then once you've built rapport, administer the ASQ. Are they suicidal? Ask the four questions, right? If they do screen positive, follow it up with the CSSRS to understand their ideation plan and intent and their means. And then reduce risk. Collaborate on the safety plan with the individual, right? Let them come up with the answers in the safety plan, right? Collaborate with them so they own it. Um, and then um, once you've kind of done that, um, you can support them by following up with them. I think sometimes what's really helpful is uh, if it's a kiddo, like connecting with the local social worker or school counselor so they know what's going on, having an ROI filled out where you can then share the safety plan with schools. Uh, and so there can be another, protective factor there. Any questions about this particular case study and what you would do differently, maybe? Or,
I don't see any questions at this point.
okay. So here is a case study with a 45-year-old man with firearm access. 45-year-old man, veteran, presents following a recent divorce and job loss. He endorses active suicidal ideation with a specific plan involving a firearm he keeps at home. Um, he reports feeling like a failure and that his children will be better off without him. He's high risk due to plan intent and access to lethal means. So, this is just using the framework how we would approach this individual, but I'd be curious to know if any of you guys might approach this differently. But using the CARES framework, the first step is to connect with that individual, acknowledge the profound pain and loss he's experiencing, and then use empathic listening to validate his sense of failure while gently introducing the possibility of hope and alternative solutions, right? At that point, when he's suicidal, you want to assess using the CSSRS to screen for positive and active ideation, specific plan and intent, and access to means. And at this point, you might want to assess protective factors such as children, anyone that they're close to. It could be a coach, could be a pastor, it could be anyone that they're close with, children, and stratify their risk to see if they require immediate intervention. And then in this case, you want to prioritize lethal means safety. So in this case, they have access to means. So you want to counsel them by collaboratively arranging them for firearm to be temporarily stored with a trusted friend or law enforcement. And then complete the safety plan with emphasis on calling 988 or the crisis line and contacting his brother identified support. You may want to discuss voluntary hospitalization for crisis stabilization if safety cannot be established. So in this case, let's say this guy, you've done everything, you've established rapport, you've assessed him for risk and safety, and they agreed to the mean safety plan. Um, but uh, maybe they won't commit. So in that instance, you may want to ask, like, do you feel like you can keep yourself safe home alone? If the answer is no, then at that point, that person may need hospitalizations in order to be stabilized. And that happens sometimes. If they feel like they can't keep themselves safe, that's really a good indicator that they need to be hospitalized for stabilization. Um, and then obviously identify reasons for living if you can with them, and coordinate with mental health services for intensive outpatient care. Or in this case, he made it inpatient. So, any questions on this case study and how you might approach it?
Yeah, we do have a question, and maybe
Yeah,
another one that just came in. The first one is, what do you do if they won't secure the firearm in a safe place?
right. If they won't secure the firearm in a safe place, then at that point you may need to, let them know that if we can't secure the firearm in a safe place, and then we need to notify law enforcement that there is a situation in the home, and they may need to come to the house and make sure that that is secured. Um, that's a possibility. If someone's suicidal and they have means to a firearm, um, it's not up to the crisis worker to go in and take the firearm away, right? If they refuse. So at that point, we might need to include law enforcement to say, hey, we have a situation here. Person's actively suicidal. They have access to means. We need to clear the house of any means right now before we can continue the assessment.
Right. Okay, thanks. We have another question from Valerie. Can you explain again when a client should be hospitalized? Initially, I thought it was when a client is high risk, but this example
Yeah.
shows a safety plan being created.
Yeah. So let's say you're attempting a safety plan and you can't, and they won't commit to a safety plan, and they are exhibiting these signs of suicidality. At that point, then um, they would be, hospitalized, or we would want to hospitalize them, right? If they can commit to a safety plan and they did say, okay, yeah, we can lock up my firearms and put them away somewhere safe, and yeah, I'll follow this safety plan that includes, distance between the means and me, then that's great, right? But if they can't commit to the safety plan, right, and they can't keep themselves safe, then at that point, that's when hospitalization is encouraged.
Gotcha. And Sandra mentioned in the chat providing a gun lock. Could you talk a little bit about how gun locks can be used and useful?
Yeah. So when someone's like really suicidal, if they have, think about it this way. When someone's suicidal, it means they're like in an acute phase of going from passively thinking about it to actively wanting to do it. That activation period does only last a few minutes,
Mhm.
and then people eventually will de-escalate, right? So within those few minutes, in those moments when that person's actively suicidal, if they have access to means that's right next to them, like, fully go loaded gun that's not on safety, boom, boom, it could be rash decision and it's over. But if we can create uh safety between them and their lethal means, meaning we put that thing in a safe somewhere that's again, it doesn't prevent them from suicide, right? But the longer it takes for them to access their means, the more of a chance we have to disrupt them from acting suicidal, and they may actually change their mind after a period of time. So we just want to create distance between them and their means because those moments count.
Gotcha. Okay, that's all the questions we have for now.
Okay, great. Okay. So here's just a poll, right? Given the following three scenarios, which client presents the highest immediate suicide risk? You guys tell me in the chat.
All right, we've got some responses coming in.
Mhm.
I see a lot of C's.
Yeah.
C, 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 C.
C is the correct answer. Um, yeah, it's pretty obvious, but I just want to see if you're paying attention. Yeah. Yeah, so C reports a specific lethal plan, clear intent to act within the next 24 hours, and has taken preparatory steps, wrote a note, gave away possessions, and to continue living. Yeah, that's much different than client A, who has frequent passive thoughts of being better off dead, but denies any intent or plan. So good job on that one, guys.
And we did get a comment in the chat
Yeah.
that I thought you might like to talk about. Frank said the thought of taking action is connected to the part of the brain that thinks of the consequences of that action. Alcohol cuts that connection. So restricting access to alcohol is as important as restricting access to firearms.
Yeah, that's a really good point. Um, if you know that they have been they like to self-medicate using alcohol, a lot of times alcohol can reduce the inhibitions of somebody from acting through on suicide. So yeah, I think that's a really great point. I think if you know somebody is suicidal, like not getting just getting rid of the means, but getting rid of the alcohol, anything where they're, because alcohol is a form of suicide, right? It's just any form of self-harm that you can think of, whether it's them drinking alcohol or booze or stockpiling pills or any of that stuff. Yeah, you're right. That all needs to be um, thought of as terms of mean safety, in terms of like getting that maybe out of the house. Questions or comments?
I don't see anything else right now, but keep them
Cool.
coming.
Cool, cool. All right, this is just a slide that you guys can use when you leave here, like when to use each suicide screening tool. And then, I personally just like to use the PHQ-9 item 9 because it's a single question. But you can use it when you're doing intake or annual assessments, if you're monitoring depression, if it's a new episode of care, or a client reports sadness, withdrawal, or hopelessness. And all it does is flag suicidal ideation. It does not assess intent or lethality. So someone says, yes, you know what? I am feeling like I don't want to be around anymore. Move into the ASQ, which is four questions that you use when a client appears emotionally overwhelmed, right? And they score positively on the PHQ-9 item 9. And maybe they show sudden behavior change, or there's a crisis, right? Or it's in a school setting, right? So what it does is detect suicide risk in under a minute, and then it includes an acute question for imminent danger, right? So any clinical rule is if there's any yes, then you want to do a brief safety assessment. If it's acute, yes, then we want to look at emergency safety response at that point. So the CSSRS, once you've, flagged somebody and they say, yeah, I am feeling suicidal, then we go through a series of questions to understand kind of their severity. Um, and so that's when you would use the CSSRS, right? And then you want to document their ideation, whether it's passive or active, and if they have a specificity of plan, their intent, their behavior, whether they've had past attempts or preparatory actions, and any risk factors and protective factors that are important to them. And what this does is going to assess ideation intensity and frequency. It's going to document specific plans and intent, and it's going to track preparatory behaviors and past attempts to provide you a risk stratification, low, moderate, or high, as to what the next step is with this individual. So, key takeaway, the CARES framework is not a rigid protocol. It's just something we use to kind of remind ourselves what we're going to do during any type of crisis assessment. We want to connect, assess, we want to like reduce risk and empower that individual through safety planning, and then we want to support them with some follow-up.
Um, Connection is really the foundation. Your alliance with that individual, your therapeutic alliance, it reduces risk more than any single intervention. Clients have to feel seen, valued, and believed. So just being there, being yourself, right? It doesn't matter what you say. You are the intervention, right? And that's the most important thing is connecting with those clients. Remember, assessment is continuous. Suicide risk is dynamic. So screen universally and assess thoroughly, but reassess frequently using validated tools. If it's especially if it's a known someone that has had attempts in the past or is frequently suicidal. Risk reduction reduces requires action. So be intentional about the safety planning, right? Collaborate with that individual. Um, and lethal means counseling as well. Don't be afraid to talk about it, right? These interventions save lives. If we can get somebody who's suicidal, just lock up their firearms somewhere safe, it can make the difference between life and death, right? And empowerment builds resilience. So, you know, sometimes I teach clients like how to breathe, how to like control their heart rate when they're in a crisis. I teach them grounding techniques, right? So giving them certain tools, they can use them within a crisis can build resilience. And then I think this is really important, guys. So, you guys are clinicians, right? So self-care is extremely important to sustaining the work, right? We're in positions where we deal with people's traumas all day, and that can be heavy work. You can suffer from vicarious trauma. You can get burnt out really. You know, you may feel like your needs are never taken care of, right? And so it's really important. I just want to remind you that you take care of yourself, and that means, you know, getting supervision and consultation, right? Having someone to talk to about your cases, right, can be extremely helpful, really, and cathartic, and debrief with somebody. Maintain clear professional boundaries, right? Around your caseloads and limits, right? You want to show up for every individual, right? But you can't be solely responsible for everybody. So, you know, set your boundaries, right? And recognize vicarious trauma. I've walked into many situations where the situation was emotionally charged. Somebody just lost somebody that day, and I'm in the house, and everybody's grieving. It's hard not to feel emotionally affected by that. I found myself crying, grieving, just like they were. And, I needed to talk to my supervisor about it just to process it, right? That's self-care. And then personal wellness practices, guys. You deal with heavy work. I appreciate the work you guys do, but it's important that you go for walks, get your exercise, get your sleep, right? Do the self-care things, whether that's meditation in the morning or stretching and exercising, right? Do the self things that allow you to show up for clients and feel good about it. Any questions, you guys?
I don't see any questions here.
Okay. Here's some references and resources, you guys, that you can use if you want to dig into some of the safety planning. So Stanley and Brown is a really good safety planning intervention that you can use and read more about. Um, and then there's just a lot of other good resources here that are really interesting. So if you're, more interested in learning more about suicide prevention, just what some of the empirical findings are out there, using different screeners and tools, and then you can also go to the National Institute of Mental Health or the Chan School of Public Health. SPRC has some really good resources at sprc.org. And then these are just your basic crisis resources that people can use. And yeah.
Great. Well, so Scott, I've got a few questions for you.
Yeah.
So some of them are clinical, some of them are legal.
Yeah.
If you're game, also I would still
Yeah.
while Scott and I are having a little chat, um, please feel free to drop any additional questions that come to mind in the Q&A or the chat, and
Yeah.
we're happy to still entertain those. So I guess the first question I have is, if you're working with a client and they deny having suicidal ideation, but I don't believe them, what do you do?
Yeah. Look at behaviors. They tell a more important story than sometimes words, right? So how are they behaving? Um, and then pay attention to their affect and recent stressors. When they're saying, I'm fine, but behaviorally they're giving away their prized possessions and they're doing other things that make you think, this is someone who's trying to create closure in their life. Um, use the Columbia scale to anchor your assessment, right? Ask them the question, right? Really get down to it. And then that way, you can err on the side of safety, and document your rationale.
Mhm.
Yeah.
Okay, so like what you're saying basically is that not just their words, but their behavior is a language, really, right?
Absolutely. Yeah,
Yeah, okay.
absolutely. Someone may say, I'm fine, don't worry about it. But next thing you know, they're stockpiling pills and they're telling
Mhm.
people like, hey, I feel like such a burden to everybody. And, they're starting to use alcohol more and more and they just lost a recent loved one. And, yeah.
Right. Okay. Thanks.
Yeah.
So how would you differentiate uh, passive from active suicidal ideation?
Yeah. I think passive thoughts are about escape. And, many times people are just want to escape the pain. So I wish I wasn't here anymore. Or I wish this would just end. I think about it passively, but active thoughts include like a desire, a plan, or intent. Like I just want to die, and you know what? I think I'm going to do it this way, and I'm going to wait till this time period before I do it. Um, so, um, that's a little bit different. When somebody talks about their plan or intent, that's when you know that they're active.
Got it.
And when in doubt, use the Columbia scale to
Mhm.
just assess them, right? Err on the side of safety.
Right. And what do I do if a client refuses to engage in safety planning?
That's a tough one. I try to understand the refusal, right? Sometimes it's fear or shame or they're angry. Um, and so, validate their emotions first.
Mhm.
And I think offer like a just a minimal viable plan, right? Maybe it's one warning sign, a coping skill, one person you can turn to support, and then here's a crisis number you can use, right?
Mm.
If they don't want to safety plan, right? And if they can agree to that, that's fine.
Right. So like what you're saying, I think is the whole planning process or all the steps in a plan might feel overwhelming and like, no, I'm not going to do it. But if you keep it
Right.
simple, okay.
Yeah, if you keep it really simple and offer some suggestions that they can say yes or no to, can be helpful.
Yeah. We do have one question that just came in on the chat. Um,
Yeah.
Devin asked, when asking a person about their triggers and stressors, what's another way to word it? He says, I'm starting to realize some people don't like the word triggers and stressors.
Yeah, I like to say like when you feel a crisis coming on, where do you feel it in your body?
Mm,
And then and then also are there certain people, places, or things around in those moments?
that's helpful. We have another question in the chat. What if a client agrees to a safety plan, but you don't think they'll follow it? If you think they're just telling you what you want to hear?
Yeah, that's a tough one, right?
Mhm.
Um, so I would include other people in it. Like if it's a student, I would include like the school counselor to review the safety plan with the students so that everyone is on the same page of what they will do. Um, and then if they're just giving you lip service, fine. But as long as other people know what the safety plan is and what the plan of action is going to be, if they
Mhm.
deviate from that, then that's a corrective action somebody can take with them.
Gotcha. Okay. One more question I had. How do I approach like a conversation about firearms, without
Mhm.
losing rapport?
Yeah, that's a really good question, right? So, what you can say is, hey, I'm not here to take anything away from you or, prevent you from owning anything, right? But for what I want to do is for times where you're feeling really activated, I want to make sure that in these acute times, you don't have access to this.
Mhm.
Right. And so, can you work with me on putting this in a safe place? I can keep it at my house whenever you want it or you need it. Like, you can come to me, like it's in a safe place, but I'd feel more comfortable if it's okay that I hold on to it until we get through this.
Mm,
And most people are going to be, yeah, that's understandable. Right. Um, and most people will work with you.
great. We had one question from an attendee. Are there legal consequences for a safety plan that failed?
No. So, you're not legally obligated by any means should like not follow their safety plan and commit suicide, right? At the end of the day, it's their choice. You can only give them the tools and be there for them and do everything you can to prevent suicide. But at the end of the day, someone takes a dark turn and they do it. Um, it's not your fault, right? It's not because you didn't do an effective safety plan. Um, it's because they became in such an acute state that they couldn't access, you know, other things to help themselves, right? And so you know, don't feel like you're somehow legally obligated because you created a safety plan and somebody did something. No, that's not a legal document. It's just a way to prevent them from doing anything.
Mhm. And someone, Maureen just said in the chat, documenting the safety plan to protect yourself. What do you think about that?
Yeah, what I like to do is document the safety plan. I sign on it and I have the client sign it.
Mhm.
And so once we both sign it, they get a copy, I keep a copy, and yeah, then that's the way I handle that.
Mm, got it. Um, so legally speaking, since we're talking about that,
Mhm.
when, as a clinician, am I legally obligated to try to hospitalize someone?
Yeah, typically when somebody's at risk of hurting themselves or others, you're legally obligated to hospitalize that person, right? And in Illinois, there's a statute that allows involuntary admission when someone is a clear danger to themselves. Okay?
Yeah. Um, and so do I have to call 988 or 911? Like even if the client doesn't
Yeah,
want me to?
so right. So your agency, depending upon where you work, a couple things. You would call 911, have EMS escorted out to the location. Police would probably show up to help escort that particular client to the stretcher, where they would be taken into the local ER to get medically cleared, and then from there get a psychiatric evaluation to see what, hospital they should go to.
Mm, okay. And so like for in this instance, in this
Yeah.
scenario, how much do I
Yeah.
document? Like, what do I have to include?
So, you wanna document their intent, plan, any access to means, and document that the client won't commit to safety.
Mm,
Okay. So doc your assessment thoroughly. And again, Illinois statute allows involuntary admission when someone is really in clear danger of hurting themselves or others.
yeah.
Yeah.
Okay. Thank you, Scott. That's been super helpful.
Yeah,
I want to encourage anyone, if you still have any questions, we still have a minute. So please feel free
sure.
to drop questions in the chat or the Q&A. In the meantime, I just want to thank Scott for this terrific presentation. This is a tough subject. And I really appreciate your guidance and your experience and the care with which you approach this subject. I want to thank
Yeah, no, my
everybody who,
pleasure.
yeah, yeah, and I want to thank everyone who logged on with us today. We hope you found this information as helpful as I did. I want to point you to some chat that my colleague Melissa just dropped into the chat with links to the evaluation and to the post test. And remind everybody that in order to receive CEUs, you have to fill out the evaluation and you have to complete the post test with a score of 80% or higher within 3 attempts. Both of those things by a week from today on Friday, December 19th. Unfortunately, we can't make any exceptions to that deadline or grant any extensions. We're not able to do that. If you have any questions about either of these things, though, please contact the organizers through Eventbrite, and we'll be happy to assist. And so I don't see any other questions. Scott, do you have any famous last words?
No, I just want to thank everybody for joining me. I really appreciate it. I appreciate all the work that you guys do. You guys are my heroes for the work that you do, and I hope I get a chance to work with some of you. And good luck. And there'll be a copy of the presentation you guys can access, right?
Yes.
So you'll be able to look at all the slides, and then yeah, good luck out there. And it was a pleasure to meet with all of you.
Yeah, thank you for your work too, Scott. I've seen Scott
Yeah.
in action, and he's remarkable. So, yes,
Thanks very much.
yeah, we'll send out the slides, and we'll also send an email later today with the links to the evaluation and the post test in case you didn't get a chance to grab them from the chat. And we'll go from there. So happy Friday, everybody. Do something to take care of yourself this afternoon. You've got a few minutes extra here. Go for a walk or meditate or whatever you do. Take Scott's good advice. And happy Friday.
Happy
Take
Friday,
care.
everybody. Thanks so much.
Thanks.
All right.